Hey, so we're gonna look into immune thrombocytopenic purpura, known on the street as ITP, well, in the clinic. And it was actually formerly known as idiopathic thrombocytopenic purpura because the cause was unknown, but now we know it's an autoimmune disorder. Just like with any thrombocytopenia, you'll see clinical manifestations such as bruising, hematomas, petechia, purpura, gum bleeding, epistaxis, slow GI bleeds, slow brain bleeds, retinal hemorrhage. Pretty much anything that can bleed will bleed because those platelets are too low and we can't get a good aggregate when a small little bleed starts. Diagnostic's going to be by ordering a CBC with differential, so you can rule out some other things. But if you notice some petechia, some purpura, some bruising, grab that CBC. If the platelet's below 100,000 and it's kind of isolated, then we're looking at thrombocytopenia. If it's not isolated, then we'd look at pancytopenia or anything else. We have to look at thrombocytopenia etiology in its entirety because ITP is naturally diagnosed by exclusion. So it's important to know some of the other causes of thrombocytopenia to include in our differential diagnoses, so that we can say, oh, not that, and then determine, oh, it's ITP. So it spells out platelets there for you, but some of the causes of ITP include platelet disorders, ITP being one of them, leukemia or lymphoma, aplastic anemia, trauma, transfusion, enlarged spleen, liver disease, lab error, ethanol, endocarditis, toxins by certain medications, and sepsis. For ITP's pathogenesis, it is, like we said earlier, it's a dysregulation of the immune system, so it's an autoimmune disease. They believe that it's probably T-cell dysfunction, but they're still running studies on that. But it looks like it's antiplatelets forming antibodies against glycoproteins, and that can cause some phagocytosis in the spleen and just a lot of overall damage. Plasma levels are typically unaffected, and it's that isolated thrombocytopenia. But we'll get into here in a few minutes some cases in which the plasma levels could be affected. Stay tuned. So manifestations, like we mentioned there in that first slide of the bleeding and bruising, anything that can bleed will bleed. You might see some splenomegaly. Platelets are usually going to be below 100,000, but they could be lower than 30,000, especially for ITP diagnosis. 30 to 50,000 usually. For treatment, when it's acute, you're going to throw some corticosteroids at them and bring them back up. Immunosuppressants and thrombopoetics are used to treat it chronically. If it's uncontrollable, which you can see in the case of hepatitis patients, you might have to do some PRN IVIG or scheduled IVIG to help bring those platelets back up. And in some cases, just take the spleen out altogether. So I have a case study for you. Kind of based it on a family member of mine. So a 62-year-old female presents to the ED via POV. History of ITP, managed with heme. And after inquiring if the patient has started any new meds to maybe cause this epistaxis, given her ITP history, she reports that she had a terrible sore throat and started taking her husband's old Bactrim prescription to try and get rid of the sore throat. And upon further examination, you notice she's got a lot of generalized bruising and diffuse petechia and purpura all over her body. So without seeing any labs, what are some differential diagnoses? Well, we would maybe look at her MAR, see if there's any other additional meds. She shouldn't be anticoagulated on top of the ITP, but you never know what patients and providers are going to do. Is she sick? Did she have some trauma? We're looking at what might be going on and looking at some clues there of things that she reported. Vital signs are pretty much normal. Lower end of normal, I guess. And heart rate's 92, so it's trying to be tachy, but not there yet. CBC shows pancytopenia. Now, the text says that in the case of thrombocytopenia, the platelet will be isolated. However, in this case, because of the uncontrolled epistaxis, we notice that the whole blood was diminished, so she's having some pancytopenia. But in the case of ITP and bleeding, you'll notice that the pancytopenia may be present. However, the proportion will be significant compared to the other blood component values. The platelet is 26,000, which is very, very, very low. But then we look at the RBC, WBC, H&H. They're concerning, but she's not needing a blood transfusion for those. So proportionally, the platelets are very significantly low compared to the other blood components. So what's going on with this patient? Well, she mentioned that Bactrim. What do we think the diagnosis might be? And what's our plan for her? That Bactrim further lowered her platelets in addition to the chronic ITP that she had. So we're looking at thrombocytopenia and epistaxis and even some pancytopenia. A person with ITP needs to be cautious about the meds that they take because various meds can interact with platelet levels even further, and Bactrim's one of them. As far as the plan goes, I mean, we got to do our ABCs, so airway's fine, breathing's fine, so we got to look at circulation. So we're going to stop that bleed because we want to make sure circulation doesn't get mucked up. We'll maybe while we were waiting for that CBC, we did some TXA and put a rhino rocket in, and we've been monitoring her. If she's good after an hour, then we can probably discharge her on the basis of the epistaxis. If not, we'll have to admit her for further hemodynamic monitoring, possible blood transfusion, and further intervention or treatment. Regardless, because of this acute episode of furthering her, it's like thrombocytopenia on top of thrombocytopenia, acute on chronic. We'll probably throw some corticosteroids at her, like maybe a 7-day course of prednisone, and have that rhino rocket removed after 48 hours, whether that's in the hospital or if she was discharged, then her PCP or ENT can go ahead and take it out. We're going to tell her, stop that Bactrim, yo. Can't be doing that. And also just educating her, like, listen, you cannot take any drugs over the counter or prescription without letting your provider know first. This is bad news. Platelet being 26,000, you could end up bleeding out, and maybe she could have if she hadn't come in. Even things like ibuprofen can interact a little bit, but definitely, yeah. She's got to team up with her provider to decide what she's going to take and not just make decisions on the fly by herself. She should definitely follow up with heme for reinforcement of everything and maybe repeat some labs see if her platelets are trending up and see if any further treatment is necessary. Thanks for playing. Hope you have a great week. Here are my references. Bye-bye.